Hi guys, this is Charles. I'm one of the surgeons at Melbourne Veterinary Specialist Center. And today we're doing an interesting case, which I haven't done one of these in a while, which is a soft tissue sarcoma of the ischiatic tuberosity. If you haven't already done so, please subscribe to our channel. Make sure you turn on notifications so you'll get a ding on your phone next time we live stream. Now, unfortunately, our battery is going dead on our streamer, and so we may not be able to make it all the way through the broadcast, but hopefully we'll get through the good stuff. So we've got a nice biopsy tract here, and confirmed to be a grade 2 soft tissue sarcoma. Now, the issue with this one is that it's attached to the ischium, so it's kind of firmly fixed there. And so I'm going to have to probably cut off a bit of the ischium in order to get a complete or comfortable margin on this thing. So I'm starting my skin incision right now. And so there are some nerves in the area that we have to be kind of aware of. And those would be the sciatic nerve, the arbitrator nerve, and the caudal rectal nerve. And I don't think any of them are really at risk, but we are aware that they're around, and we will kind of be careful. I might have you retract on that for me, please. So we did a CT scan on this beforehand, confirmed that there was no evidence of metastasis. There's one lymph node that's a little bit big. So I'm coming down onto the semitendinosus there, and we can see that we're getting just a little bit of twitching. And that is not that the dog is feeling it, although he is getting a bit light. It's always a battle juggling the depth of the anesthetic and the blood pressure and stuff like that. So we are down to 5% on the streamer, so again I apologize if that ducks out. I'm just being really cognizant of how deep I go with my dissection because I don't want to cut into the tumor. It is completely surrounded by fat, and so I don't have to get a huge margin on it, but I still do need to be careful. So let's get a couple of big gulpies in here. So I'm going through semitendinosus there, and that's going to be my margin, part of my soft tissue margin. I'm just going to dissect that right down onto the ischiatic tuberosity, and we should have no issues with function associated with cutting these muscles. Okay, so I'm down to the ischiatic tuberosity underneath. I'm just noting the sciatic nerve is going to be right down in here. Okay, so our sciatic notch. Down to ischiatic tuberosity right there. Do you want to palpate that, Jacob? Can we get our saw, please?
Yeah. What? I'll show you
Question about saddle thrombectomy. We used to do them in cats, but we don't do them anymore because it doesn't appear, doing surgery on those does not appear to improve survival. Too big. Too big. Too big. Pretty good. Probably that one. Yep. We're just choosing our saw blade size. And coming down from the top on the ischiatic tuberosity as well. Part of the benefit of removing the ischiatic tuberosity is that you'll have less pressure on the incision from underneath, so you might be less likely to get dehiscence as well. The caudal rectal nerve will be kind of medial to where we're working. Obturator nerve is also going to be in the vicinity, as I stated before. Bleeder here. This is sciatic nerve. I got some kicking, twitching in the foot because I'm very close with my cautery. So this is where our caudal rectal nerve would be. This will be internal obturator right here. And got a little kick close to the sciatic nerve. And just some fat in here. So basically I've isolated the ischiatic tuberosity completely. All right, and then I'll just scrape off a bit of muscle. Did I get a Homan? Thank you. Rick, I think that's a really good idea, is to count these as exam study. And I'm down to 1% on my streamer, and so we're probably going to cut out in just a minute. So I apologize for that. We'll get our streamer charged up nicely for more surgery this week. Not quite that big. Yep. Just one for starters. And we'll get some saline as well, please. All right, so now I'm dropping this Homan down into the obturator foramen. Just cutting some more muscle off here. Coming around the corner there. So sciatic nerve is going to be right there. Let me just see if I can get some of the muscle in the guilty here. So we can see the ischiatic tuberosity there very clearly. Put some saline, please, just a few drops. Thank you. All right, I might come to the other side. Just lift that up like that. Come down underneath. Can I get a slightly longer saw blade, please? I'll just go with the big one, that's fine, just nice. So it's a bit stiff. Yeah, that's great, yeah. The other blade is a bit too wiggly, and so... Not sure if this is the same saw. I don't think, I think that this is it different? Yeah, this is different. Yeah, I'll go back to that. I'll just get a new blade then, this is a bit dull. Hey? Well, the one that I had was dull. And this one hopefully will be sharper.
But these ones don't fit?
They don't fit the connector unless we've got a different. And this blade's a bit small and flimsy again. Problem is that it's slipping down the bone a bit. Voila. All right. So, you see the mass here. We can't see any tumor visible. There's the bit of ischiatic tuberosity there that we've taken off. Yeah, so I think we're in really good shape. All right, so it is not, as somebody commented, it's not that big for a flap, and that's exactly right. I don't think that I'll have to do anything major. I may have to do a little tension relieving suture or something before we finish. I might actually take a bit more off here just so that it's not going to put pressure on the incision from underneath. A Freer elevator in here.
Can we please get a free elevator? A free elevator?
All three, yeah.
That's all right, got it.
Oh, okay.
All right, so I've taken off that bone there. Where's my cautery, please? So, then I'll get some bupivacaine, please. So that's going to be rectum, not too far off there. Never encountered the caudal rectal nerve. Yes, please. Yes. And then I'll just have you invert that bottle.
7.8.
Just invert.
Yeah.
Yeah, go ahead. Flip. Yeah.
Scary. I just won't squeeze it.
So a dose for this dog is about 8 ml. Get a little careful with the sciatic nerve there. Can we get some OPDS, please? And then we'll see if we can pull some of this muscle over the tuberosity, which again provides some cushioning. Try to prevent it causing dehiscence from the inside. I'm suturing to biceps muscle there, so it's internal obturator to biceps muscle. The other thing that it's going to do is it's going to also reduce some of the tension on the skin. So there's a question about free flaps. Free flaps can be done in animals. I've never done one. There are people that do them. They have to get microvascular training, which I have not done. I honestly haven't seen, I guess, that much need for it, because dogs have so much extra skin, and there are often a lot of other reconstructive options available, and we're not as concerned about cosmesis as we are in people. So I think that a lot of the times that people use free flaps is because they know how to do them and they're looking for a diagnosis to fit a technique rather than a technique to fit a diagnosis. So often it's a case of, I've got this really cool technique that I can do, but it's a question of whether you really need to do it. So picking up that fibrous tissue, the periosteum, really helps that suture bite and hold, and the aponeurosis of the tendon. Now we're back up to 2%. It's fighting back. All right, let's see what we've got here. So that probably will be under too much tension. We'll close it primarily, but not absolutely. So I've got a lot of extra skin here. So what I could do is make a rotational flap, so make an incision here and just bring that down. So that would close to there. It's just right here, I think, that the that would close there. It's very close, very borderline as to whether I need to do a flap here or not. I think to be safe, I will. So what I'm going to do something like that. Okay, and then when I rotate that around, can I get another cautery, please? Yes, please. Thank you. Now, if I was concerned about my margins, I would not be doing any kind of reconstructive flap. Nah. Because I'd be afraid of contaminating my donor site. We good?
Yep, all good.
trying to bring some fat along with the flap. Getting a bit light again. Okay, can I get some OPDS, please? And just watch your head. All right, so I'm going to bring this point down to here. I'm going to try to grab some of that nice dense connective tissue. And I'm just trying to space these sutures in a way that it's going to distribute that tension. And then we can see that we've got an uneven, so this is a longer span than this. So what we do is we're going to just bisect the segment. So we're in the middle of that segment. I'm going to bisect the other segment as well, and we'll just redistribute that extra skin across the whole incision. These are not working very well for me. So again, bisecting the two segments. going to start doing the same thing up there. Get a bit of suture there. Yeah, you've got a needle driver. I think we're okay. Thank you.
Thank you. Stretch.
Thank you. You can push that table out of the way a little bit if you'd like. So there's a question about why I left Southpaws. And the honest answer is that I was made redundant. So after I sold, when economics got a bit tight in Melbourne, the person that I sold to decided that my salary wasn't a good investment. And so I got sacked. Which was interesting, to be sacked from the place you started.
It's crazy.
But I'm very, very content now with my career. I will have some 2.0 PDS, please. Do you want to grab some 2.0 PDS as well? And I will, thank you. Yes, we will. Somebody commented there must be some good drug dealers in Melbourne for somebody to make that call. Can you come around this side for me, please? Let's take that. Jacob and I are going to start running into each other. So I will probably abandon ship in a minute. So there are going to be sutures that will have to be taken out in this dog because having trouble burying all of these. Just going to put some more simple interrupteds. Along here to bring some of these little corners out. So there's a question about sentinel nodes, and do I remove them in every case? And I'm not a big, not that I don't believe in taking sentinel nodes, but I mean basically, for the most part, taking sentinel nodes is a diagnostic procedure rather than a therapeutic procedure. And so in a tumor that is unlikely to metastasize, I'm not sure that it's worth the effort. If you had like a high-grade mast cell tumor or something like that, then taking sentinel nodes might be worthwhile. Again, primarily as a diagnostic exercise to see whether you need to follow up with chemotherapy or not. Interestingly, with grade 3 soft tissue sarcomas, so this is a grade 3, but with this is a grade 2, but with grade 3 soft tissue sarcomas, they've shown that chemotherapy does not improve survival anyway. And so I'm not sure that knowing if the nodes are positive or not really makes much difference. Jacob, I think we'll come back and do cruciate skin sutures all the way through. All right. All right. So there's a question: do dogs get atherosclerosis? They do not. So yeah, that is not something that we see in animals. Basically, no vascular diseases in dogs. Cats can get some issues with. I'm just going to move the camera a little bit. All right. So cats can potentially get some vascular disease, but dogs really don't. And so that's not something that we see. So a book to study anatomy, I really like, I mean, nothing beats Miller's dissection of the dog, except there aren't as many good pictures. There are some color atlases maybe that have nicer pictures. And often, to be honest, I just do an internet search of the area that I'm interested in, and then just look for diagrams that come up on my internet search. Regarding inking margins, I just ink the whole margin in one color. The thinking is that if it's dirty anywhere, it doesn't really matter where it's dirty, and so I don't really care if it's the dorsal margin or the ventral margin or whatever. If it's dirty, the whole incision is dirty, I'm going to treat the whole incision with whatever adjuvant therapy we're doing. I am not in Singapore. I just went to Singapore for 3 weeks doing a locum. I'm back in Melbourne. And Arturo wants to make a YouTube channel. Let me know if I can help out anyway. And hi, Rick in Townsville. Just make sure there aren't any other questions. All right, well, I'm going to go ahead and wrap that up. If you haven't already done so, please subscribe to our channel. Make sure you turn on notifications so you'll get a ding on your phone the next time we live stream. And hopefully we'll see you again this week. Thank you.